Hello, this is Ron Broussard, and today we'll be talking about Chapter 7, Anatomy, Physiology, and Medical Terminology. So, with this class, we are going to give you a gross overview of the human body, how it's made up, how it works, and medical terminology that you can use to communicate with other healthcare professionals effectively. Um, do not be overwhelmed with this class. This is, a 3 to 4 hour block of instruction that is making up for semesters worth of teaching. So it is a very gross overview. Try to get as much as you can and then slowly add to your toolbox. Okay. Now, anatomy refers to how the body is made. Physiology refers to how the body works. Okay. So when we're talking about structure and how things are made up, we're referring to anatomy. When we're talking about how things work within that structure, we're referring to physiology. Now, medical terminology, a lot of it is derived from a Latin background. So if you guys have a Latin background, you might be able to knock this out of the park, no problem. Now, what medical terminology allows you to do is it allows you to work with medical professionals and communicate effectively, efficiently, and concisely within the medical team. Okay, now with anatomical position. Anatomical position is going to be our baseline for describing positioning on a patient. Okay, so with anatomical position, our patient is standing, facing forward, arms are at their sides, palms are facing forward in a supinated position. Okay, palms are forward here. Right? And this is our baseline for how we will describe things for our patients. Now, of course, when we say left, it's referring to patient's left. If we say right, referring to patient's right. Now, if we have any offset for how we find our patient from this, okay, we can document that. So let's say their right foot here. We have, rotation, and the toes are starting to point inward on that right foot. So the whole leg's kind of twisted inward. Well, that is movement from our anatomical position. So we could chart that as the patient has medial rotation of the right leg. Okay, medial rotation because medial is towards midline, okay, center of the body. So that could be a way of how we use anatomical position. Now, you guys just need to know anatomical position, how to describe it. So standing erect, facing forward, arms at their sides, palms forward or in a supinated position. Okay, now here are some positions that we can find our patients in. The supine position. Supine position is simply laying on the back. Okay, patient is laying flat on their back. Um, Now, times when you need to use this position or place the patient in a supine position, we use this position often for shock. Okay, if you have to manage an airway, like if you're going to insert an airway adjunct on a patient, you'll be putting them in a supine position. If you need to ventilate a patient, and manage their airway and breathing, you'll put them in a supine position. But again, supine position, laying on their back. Okay, the prone position. Prone position is a face down position. Now, we obviously do not want to leave our patients in this position. There are times, especially with COVID, that we found that rotating patients into a prone position helps promote, movement and help displacing things within the lungs. So we put patients in a prone position in like the ICU setting. We will not be really using this in a pre-hospital setting. Okay, so if we find a patient in a prone or a face down position, we'll move them into a position where we can better manage their airway. Okay, now, right lateral recumbent position. Simply put, the patient's laying on their right side. Okay, now, secondary to that, we have a left lateral recumbent position. Okay, now the left lateral recumbent position is most times how we'll position a patient to, say, protect their airway when, maybe they're having a little issues with vomiting. put them in a left lateral recumbent position. So that way when they throw up, we're not worried about them. Well, we are still concerned about it, but their vomit goes off to the side versus if they were in a supine position and they throw up, now we're worried about them aspirating in their vomitus. Okay, so left lateral recumbent position here, patients on their left side. We could use this to help, if we have a unconscious patient where we're worried about vomiting, no concern of spinal injuries, and in that position, they're able to help manage and maintain their airway on their own. Okay, we have a Fowler's position where the patient is simply sitting up. Oftentimes, too, this will be a position of comfort for your patients with shortness of breath and difficulty breathing. Okay, we have the shock position. Now, I will tell you, haven't seen this position used much for shock. Oftentimes we'll just simply put our patients in a supine position, but with the shock position, now some agencies may still use this, but with the shock position, you elevate the feet up. What that does is it uses gravity to push blood down back towards the core, and the idea is we increase our blood pressure utilizing the help of gravity by elevating the feet 8 to 12 inches. Okay, some places encourage shock position, some places do not. All right, now referring to anatomical planes. Now, anatomical planes, a simple way to look at this is kind of how they separate the body. Okay, so we have the frontal plane or the coronal plane. Now, the frontal plane separates the body into anterior and posterior, or front and back halves. Okay, you have your sagittal or median plane. Now, the sagittal plane will separate the body into left and right halves. Now, if that separation is perfectly down the center, we call that the mid-sagittal plane. Okay, and then you have the transverse plane. Transverse plane separates the body into upper and lower halves. Now, terms of directions. Now, I know you guys are going to get some questions on this, so we need to make sure we have a good understanding here. So, this imaginary line that we're going to draw down the patient's body, that is going to be considered midline. Okay, so we have an imaginary line, or the mid-sagittal plane. We have that imaginary line drawn down the center of the body. Okay, that is midline. Anything toward midline is considered medial. Anything away from midline is considered lateral. Now, referring to proximal and distal. Proximal and distal refers to its point of attachment. Okay, so let's use the arm for example. The point of attachment for the arm is the shoulder. So if we are referring to something and it's closer to the point of attachment, it is proximal. If it is further from the point of attachment, it's considered distal. All right, closer, proximal, further, distal. Okay, so the way you may see it on an example, so that's what people want to know. Let's say we're referring to different spots on the arm. Okay, so let's say the elbow is proximal to the wrist. Why? Because the elbow is closer to the point of attachment than the wrist. The wrist is distal to the elbow. Why? Because the wrist is further from the point of attachment than the elbow. All right, so that's how you guys will see it on the exam. Okay, now another place you guys, may need to use distal and proximal. So let's say our patient has a deformity here on the lower portion of their femur bone, okay, just above the knee. All right, well, point of attachment for our leg is right here in the hip, right? Well, we have this long femur bone that comes down right here. Okay, so if we have a fracture way down here, if we have a deformity way down here, well, we would describe that as a deformity on the distal femur. Okay, why? Because it's the lower aspect, the point further away from the point of attachment. Okay, remember proximal closer to, distal further away. Okay, palmar is referring to the palm of the hand. I'm sure you guys picking that up. Okay, and plantar is referring towards the foot. Now, moving over here. Inferior referring to lower, superior referring to higher up. Now, anterior and posterior, okay, anterior, posterior versus ventral and dorsal. Now, they can be used in the same sense most times. There are some exceptions, okay? Now, when we're referring to anterior and posterior, you need to think of it as if the body is in locomotion, so moving forward in anatomical position. Anterior is the portion of the body that breaks through the wind first. So the anterior portion is going to be, pretty much everything on the frontal aspect of this patient is going to be anterior. Okay, whereas posterior, the part that breaks wind last, is the back side of the patient. So everything on the back side here. Okay, that is going to be posterior. Now, for the most part, ventral and dorsal, do go hand in hand with anterior and posterior. Now, ventral means toward the belly. Okay, dorsal means toward the back. All right. Now, a place where that does not work, because anterior, if we're talking about the anterior portion of the foot, that's going to be the front up here by the toes. And the posterior aspect of the foot, that's going to be way back here by the heel. Now, we can't apply ventral and dorsal here because ventral, is towards the belly, dorsal is towards the back. So the dorsal aspect of the foot is actually the top portion of the foot here, whereas the ventral aspect of the foot is the bottom part here. All right, I'm not trying to confuse you guys because, like I said, a lot of times we can refer to these, as the same. But there are some exceptions, all right, and that's an example of it. Okay, now we have different regions of the body. Okay, cranial region referring to the head. Now the occipital region specifically is referring to that posterior aspect of the head. The cervical region referring to where we have our cervical spine. Okay, this inferior angle of the scapula is referring to the lower angle of the scapula here. Okay, the lumbar region is referring to our lower back. Now the flank is referring to the right and left sides of our patient. Okay, we have the sacral region, okay, is where our sacrum is located. Okay, we have the thigh and the leg. But one thing I want you to know here is the back of the knee is the popliteal region. Okay, we have the plantar aspect of the foot, and we have the dorsum of the foot. So the dorsum of the foot is going to be the top portion here. Okay, we have the femoral region, which is the upper leg. Okay, genital region. Okay, the inguinal region. This is one that I want you guys to kind of pay attention to. The inguinal region. It's kind of where we have that crease in the groin. Okay. Okay, the umbilical region is referred to around the belly button. Okay, the cubital region is that nice little pit that is in the elbow area. Okay, and we have the thoracic region referring to the chest. All right, now describing terms of the anterior chest. Now this is going to help you guys if you're, say, needing to describe or locate any kind of injuries or document anything. Okay, so we have the mid-sternal line. So just like midline is that imaginary line that we drew right down the center of the patient, well, that mid-sternal line is referring to specifically the anterior chest, and now going along the direct center of the patient's chest is that mid-sternal line. Now, if we go from the clavicle, from the center of the clavicle, and draw that line straight down, that is the mid-clavicular line. Okay, we also have the anterior axillary line. Now, anterior, of course, is going to be towards the front. Okay, now axillary is referring to the side of our body. So towards the front, on the side, this imaginary line towards the anterior aspect of the patient's chest. Okay, is the anterior axillary line. Okay, this was kind of getting into bones, which we're going to talk about later. But you have the clavicle, the acromion. Now the area in between our ribs is the intercostal space. Now the angle of Lewis here. Now it's not really shown that great in this picture, but the sternum is actually broken down into 3 different bones. So you have the manubrium, which is the top portion of the sternum. Okay, you have the body of the sternum itself, and then you have the xiphoid process. Now notice they have a line of demarcation here for the xiphoid process. There's also a line of demarcation for the manubrium to the body of the sternum. Now it is at that line where you have the angle of Lewis. Okay, the angle of Lewis runs, pretty much right along the second rib. All right. Okay. Terms for describing the posterior chest, so that imaginary line running down. Okay, down the center is the mid-spinal line. If we go right through the center of the scapula, that is the mid-scapular line. Now, if we drew an imaginary line now along the back side here on the most lateral aspect on the back, that is the posterior axillary line. And there we go. So moving into that. So mid-axillary line. Axillary is referring to the side. Okay, so mid-axillary line, we have down the side of our patient, a straight line that's drawn down. Okay, if it's perfectly in the center on the side, it's the mid-axillary line. Hopefully this helps you guys see it a little bit better versus anterior versus posterior. So if we move towards the front on the most lateral aspect, it's going to be towards the anterior axillary line. And then towards the back, it is the posterior axillary line. Now, body cavity. So our body cavities carry vital organs. All right, that's one way to look at it, such as the cranial cavity. What does it house? It houses the brain. Spinal cavity houses the spinal cord. Okay, the thoracic cavity houses very, very important organs such as the heart, the lungs, some of our great blood vessels, okay, like the aorta, okay, are going to be in the thoracic cavity. Now, we have a dividing line now from our thoracic cavity to our abdominal cavity. This dividing line here is a thin sheet muscle that's called the diaphragm that controls our breathing, in a sense. Responsible for 60 to 70% of the tidal volume that we get is the diaphragm. Okay, that is our nice little dividing line for the thoracic cavity to the abdominal cavity. Okay, creates a nice, tight seal. All right. Now we have the abdominal cavity. Okay, then we have the pelvic cavity. Now there is nothing that necessarily separates these 2 cavities. Okay, but when we combine them, it's considered the abdominal pelvic cavity. Now, when we're talking about the abdominal cavity, you guys will need to know the body quadrants and what organs are in each of the abdominal quadrants. Okay, in the abdominal emergencies chapter, we break it down even more into 9 regions. Okay, but for now, we break them up into 4 quadrants. All right, so in our 4 quadrants, the right upper quadrant, okay, majority of the liver is in the right upper quadrant. Now, the right kidney. With the right kidney, the kidneys are retroperitoneal, so they sit towards the back and they're not in the intraperitoneal space or within the abdominal cavity. They're posterior to the abdominal cavity, but it's going to be, consider it, the right upper side. Okay, you have a portion of the colon, so you have a portion of the ascending and transverse colon here. Okay, the gallbladder sits inferior to the liver. It's this nice little green thing that they're trying to show you here. Okay, and then we have portions of our small intestines are going to be in the right upper quadrant. We also have a very small portion of our pancreas. Now the pancreas they're trying to show you is right here. Now it tapers off over here to the left side here. Now with the pancreas, okay, it does have the head of the pancreas is in the right upper quadrant, and that is also where we have the dumping of like pancreatic enzymes into the small intestines. That's where that stuff's going to occur. All right. Now let's move on to the left upper quadrant because it's kind of going to dial in with our pancreas here. So like I was saying, that pancreas, a small portion of it's in the right upper quadrant, but it tapers off over here to the left upper quadrant. Okay, actually it tapers and attaches to the spleen, which they're not showing you here, which is over here on the flank. So we have a small portion of the liver, it's in the left upper quadrant, spleen, left kidney, the stomach, here you go here, okay, the colon, so we have that the rest of our transverse colon and a section of our descending colon. Okay, majority of the pancreas and small intestines. Now, we palpate for the pancreas in the left upper quadrant. Okay, now our right lower quadrant. Okay, so we have a section of our colon here, the start of our ascending colon, small intestines, right ureter, so that is what transports urine from the kidney down to the bladder, the appendix, right ovary for females, right fallopian tube for females are going to be in the right lower quadrant. Left lower quadrant, we have a portion of our colon, so the descending colon here, moving into the sigmoid and then the rectum. Okay, we have the small intestines, left ureter, left ovary in females, and left fallopian tube in females. Now, moving on into the musculoskeletal system. So the skeletal system in and of itself is created up of a bony framework, okay, made up of ligaments and tendons. Okay, ligaments help us connect bone to bone. Tendons help us connect those muscles to bone. Okay, we have muscles and connective tissues, muscles which help us move. All right, functions of musculoskeletal system is it gives us our shape. Okay, it helps us stand how we are. It protects vital organs. Imagine if we didn't have a skull, what kind of trauma our brain would be exposed to if it was unprotected by that bone. Okay, imagine if you didn't have a rib cage and you took blunt trauma to the chest, what that would mean for those vital organs underneath. So it provides some protection. Okay, it allows for movement of the body. Okay, with work of muscles and the structure that we have, we're allowed to move how we want. Okay, also storage. Now, our body is this amazing system in that it works to maintain this level of homeostasis. Okay, so our body always wants like this nice little baseline. Okay, so let's say we want, we want calcium levels to be at a certain level. Well, say we're exercising, we're sweating, we're depleting electrolytes, we're depleting nutrients, we have poor diet. Well, our body is great in that we can work with the parathyroid gland to release hormones to pull calcium out of the bone and increase our calcium levels in the blood if we need to. Okay, let's say like we have red blood cell issue. Red blood cells are created in the bone. All right, well, if we need more red blood cells, okay, our body can send a message to the bone to help us create more red blood cells and increase red blood cells within the body, okay, within the blood flow. Okay, it's amazing in that we can work to maintain this level of homeostasis. Oftentimes when we're called, it's when the body cannot maintain that homeostasis, and we need to then hopefully help to fix it. Like if they're bleeding, we need to stop the bleed. All right, they need oxygen. We need to give them oxygen. Now, with the skeletal system, okay, we have 6 basic components. Okay, we have the skull, the spinal column, okay, the thorax, the pelvis, upper extremities, and lower extremities. Okay, so those are your 6 basic components. You're like, wait a minute, I only see 5 bullets here. Well, I get you here, upper and lower extremities. There's your 2 more. All right, so the skull. All right, now these are all fused joint sites here, and they separate into different bones. We only have one movable joint within the skull, and that is the mandible. Moves on a hinge joint here. Okay, so we have the frontal bone. We have a nice little fissure here that helps our separation, which if you guys get a chance to look at the skull that we have or the skeleton that we have in the classroom, you guys can see these and kind of work to identify these bones. So frontal bone here, we have our parietal bone here, it's going to be on the left and right sides. Temporal bone here, okay, we have our occipital bone here. Okay, you have the orbit of the eye. You have the maxilla, which is the upper jaw. You have the mandible, which is the lower jaw, only movable joint in the skull. Okay, you have the zygomatic bone, which is the cheekbone. We have our nasal bone. Now, we don't break it down much into this chapter, but we have smaller bones in the skull, like the ethmoid bone. Okay, you have the sphenoid bone, which is also located here. You guys, again, don't need to know that, but if you're wondering, like, well, I see, here we go, we have some demarcation lines here. What's this one? Okay, well, it's a sphenoid bone. Okay, in the eye socket, you have like the ethmoid bone. There are other bones within that. It goes a little bit deeper, but just focus on these ones for now. Okay, now we have the spinal column. So the spinal column is what houses our spinal cord. For purposes of this class, you need to know that the spinal column houses the cord, and you need to know how many vertebrae, okay, each individual bone there are in each section of the spine. Okay, so we have 7 cervical vertebrae. Okay, 7 cervical vertebrae. We have 12 thoracic vertebrae. We have 5 lumbar vertebrae. All right, well, they're not giving you a number, but I'll give you a number. We have 5 sacral vertebrae that are all fused, and we have 4 coccygeal vertebrae. Now, a way that you guys can try to remember this, all right? If you think of it from top to bottom, breakfast, lunch, dinner, bedtime, I get up, I eat breakfast at 7, lunch at 12, dinner at 5, and I go to bed promptly after Matlock at 9 for the rest. All right. Now, it's just a little way for you guys to help remember breakfast at 7, lunch at 12, dinner at 5, bed at 9. All right, to help remember how many vertebrae there are in each. You guys will have questions on that. So please make sure you remember, how many vertebrae are in each section. Okay, now when dealing with the skeletal system, we have the thorax here. Now, the scapula, it's going to be like that nice little wing you see on the back there, large bone on the posterior side of the body. The humerus, the bone of the upper arm. Now, the radius and the ulna. Okay, your radius is going to be on the thumb side of the arm with the palm in a supinated position or an anatomical position. So put your arm out in front of you, put your palm facing up. Okay, on that thumb side, that is the radius. Now on the pinky side, that is the ulna. Okay, now kind of moving back to the thorax here, we have the sternum. I kind of hit on it already. The sternum breaks up into 3 different bones now. So you have the top aspect, which is the manubrium. You have the body of the sternum, and you have the xiphoid process. Okay, and then you have your ribs. Okay. Now, moving down into the pelvis, and we're just going to focus on the pelvis for this. The pelvis, you have the sacrum, which is considered part of the spinal column, okay? And you have the coccyx, which is considered, again, part of the spinal column. But you have also different bones of the pelvis. So when referring to the pelvis, there are specific parts of the pelvis. These large wings that branch off here are the ilium. Okay, you have the pubis, which is in the front. Okay, and then What you're sitting on, you have the ischium. Okay, the ischium is this lower aspect of the pelvis here. Okay, so we have these three different parts of the pelvis, okay, or the pelvic girdle. You have the ilium, the pubis, and the ischium. Now, moving on into our lower extremities. Now, if you guys have taken anatomy classes in the past, this is not meant to be, understand this is not meant to be a very in-depth aspect of anatomy. So if you guys are like, well, this little prominence here has a name, it's like, we're not going that deep, trust me. Okay, the bone here, long bone of the lower leg. Okay, that's of the leg here. We have this long bone. It is the femur. The patella is the kneecap. The weight-bearing bone of the lower leg, okay, lower leg weight-bearing bone is the tibia. The non-weight-bearing bone is the fibula, okay. Then moving down to the bones of the feet, you have tarsal bones. Moving on into long bones, metatarsal bones, and then you have phalanges. Now, each one of these tarsal bones have names. Okay, you are not going to need to know, like cuneiform, okay, and things like that. All right, you're not going to need to know like each one of these tarsal bones, with the exception of the heel bone. Okay, the heel bone is called the calcaneus. Now, you do need to remember that one. Put that tarsal bone in your head. Calcaneus is the heel bone. Okay, please know that one. Okay, now on to the upper extremities. I kind of, spoiled that one with my thorax slide, but we'll hit it again. So the upper arm is the humerus. Lower arm, we have the radius and ulna. Remember, radius is on the thumb side. Ulna is on the pinky side. Now, the bone where that actually attaches to the humerus and creates this Lego hand, the olecranon. Okay, this Lego hand that attaches to the humerus, that is a portion of the ulna that allows that hinge joint, okay, connection. Now, moving down to the smaller bones of the hand, those are carpal bones. Now, those all have names. You do not need to know those for the sake of this class. Okay, moving on to the longer bones of the hand, we have metacarpals, and then phalanges are the fingers. Now, with the skeletal systems, we have different joints. We have immovable joints, ones that are fused together. We have slightly movable joints, and then we have freely movable joints. Okay, immovable joints are a good example being the ones in our skull. So the frontal bone and the parietal bones, those are fused together. Okay, those are not moving. Okay, but they're still joint sites. They're different bones. Okay, now we have slightly movable joints. This is showing you guys like areas of the vertebral column. Okay, another area where we have slightly movable joints are going to be like the bones of the bones that make up the wrist. Okay, the bones that make up the wrist, where they're kind of gliding together, those gliding joints. Okay, and then we have freely movable joints. This is showing you guys an example of a ball and socket joint from the head of the femur where it fits into the pelvis. All right, so with the skeletal systems, we have different joint motions. Now, these joint motions are, remember, we're going to describe them as, our body is in anatomical position. Now we have movements from that anatomical position. Okay, flexion and extension. Now, way you can think about that, flexion. Okay, flexion, we are decreasing the angle of the joint. So if you, do your bicep in a flex position right now and you bring that arm up and like try to flex your bicep, that is considered flexion. What are you doing? You're decreasing the angle that was within that elbow joint. Well, extension, if extend your arm to a straight arm position, that is extension. So my arm went from flexed to straight. What have I done to that joint? I've increased the angle of that joint. Okay, so that is extension. Now, abduction and adduction. Okay, now abduction is movement away from midline. Movement away from midline is abduction. Movement toward midline is adduction. So if my arms are at my side right now, and from my shoulder, I extend my arm up and out, okay, to the side. Okay, well, I am abducting that arm. I'm moving away from midline. Okay, now if I move that arm back to my side, I'm adducting that arm. I'm moving toward midline. Another way to remember this. Okay, aliens abduct. They take you away, movement away. Well, when we move back, we add. When I'm coming back to the core, I'm adding to the core. Okay, so adduction is moving back towards midline. Abduction, okay, aliens take it away. Some of you guys are like, I don't know what this dude's talking about. I'm lost now. All right. Now, circumduction is a combination of these movements: flexion, extension, abduction, adduction. What you can think of this is, think of like a swimmer's freestyle stroke, okay, or like a crawl stroke, however you want to call it. So you have a swimmer swimming in the water, and they have a combination of all of these movements. Okay, that would be a good example of circumduction. Okay, now we have pronation and supination. So think of this like the palm of your hand. So when our palm is facing forward, here we go, facing up. Like, how do you hold a bowl of soup? Okay, well, you're not going to hold a bowl of soup on the backside of your hand, right? You're going to hold it in the palm of your hand, and your palm needs to be facing up to do it. So supination, palm forward or palm up, okay, is a supinated position. Whereas pronated, you rotate that palm down towards the floor. All right, that is a pronated position. Okay, I know it's really hard to just imagine it with me in words, but that is kind of what we're gonna have to do for this. Okay, pronated, palm down, supinated, palm up. Now, types of joints. So we have different types of joints. We have ball and socket joints. Now, ball and socket joint, be it in the shoulder, be it in the hip, okay? Those ball and socket joints are freely movable. Okay, the most movable joint you have is the shoulder. Now, because of all that movement, it is the most prone to injury. Okay, now you have hinge joints. Think like the elbow, where we have extension and flexion. All right, we have pivot joints where we have limited movement. Okay, like say left and right. Okay, I want you guys to think of like your C1 and C2 vertebrae. Okay, where that C1, C2, we have some pivot there where you're looking left, looking right. There has to be a little bit of movement, but it is limited or controlled. Okay. Now we have gliding joints. Gliding joints. I want you to think of those small bones, where you're, say, in the foot, like where your tarsal bones meet up with those metatarsal bones. Well, those are joint sites, and there's some limited movement there. There's some gliding next to one another. Okay, but like the movement is limited. Now you have your saddle joint, which you think of like the ankle. The ankle is a great saddle joint when you think of it. Okay, you have some flexion and extension, you have some left and right movement, you even have a little bit of twisting movement in a saddle joint. Okay, and now condyloid joint is a joint where you can have flexion and extension, left and right movement, and then also very limited rotation. Think about the wrist. Okay, the wrist at its point of attachment with the radius and ulna would be like a condyloid joint site. Now, when dealing with bone injuries, we have to understand that bones are living tissue and they have a blood supply within them. So when you have a fracture, that does lead to bleeding, and bleeding also from the surrounding tissues, because bones never break, nice and soft edges. When bones break, sometimes they break very sharp and jagged. So a lot of that swelling that you see, well, it could be from internal bleeding from the bone itself. Now, this is showing you guys an example, like our proximal long bones here have a very rich blood supply, specifically like the femurs. Let's give that example. A femur fracture, can hold, 1,000 milliliters of blood. That's a pretty good volume. That's a liter. Like we can lose a liter of blood from a fractured femur. And that's a significant volume. Now, and that's just from the bone itself. That's not even taking into account if that bone severs and breaks and then severs a blood vessel surrounding it. And now we're bleeding from the vessel too. All right, so we are concerned with hypovolemia, especially when we're dealing with proximal long bone fractures. Now, the muscular system. Now, the muscles allow movement from contracting and relaxing. That is generated by nerve impulses from our body. We have three different types of muscle. Okay, you have skeletal, smooth, and cardiac muscle. Now, what you need to know, skeletal muscle is voluntary. You have control over that. Me bumping my gums right now, moving my jaw up and down and talking, all right, and sitting here. Y'all can't see it, but I'm using crazy hand gestures because I'm used to teaching in person, and hey, I use hand gestures when I talk, and it doesn't go away when I'm on camera. All right, I'm not even on camera now. All right, but I have control over these things. Okay, I can move around. My body, my brain is sending a message to my arm to grab something. All right, I have control over that. Those are skeletal muscles, those are voluntary muscles. Okay, controlled by the voluntary nervous system. Okay, I have control. All right, now smooth muscle. Okay, I want you to think about things like your intestines. Think about things like your blood vessels. All right. Do you sit here and think like, I had some breakfast. I had those eggs this morning. Okay, small intestines. All right, contract now. Contract now. All right, move that food through my GI tract. Ha ha ha. No, you don't. Your body just does it. Okay. Okay, so that is run on the autonomic nervous system. Okay, so through peristalsis, okay, that's that smooth muscle contraction. Okay, we're able to move the food that you ate through the GI tract. Okay. Now, through the autonomic nervous system, our blood vessels can contract or can relax to help us maintain an adequate blood pressure to keep us alive. All right. So you don't think about those things. It's run by the autonomic nervous system. Okay. But they're still muscles. So smooth muscle. You don't have control over that. Okay, and now we have cardiac muscle. Now, cardiac muscle is very specialized muscle. All right, it works on its own. It works on its own. It can get impulses from the autonomic nervous system. Okay, like, hey, increase, I want you to beat. I'm scared right now. Beat faster, heart. Ha ha. Like I'm running right now. I need you to pump faster, pump harder to get that blood, that oxygen to my muscles and get that carbon dioxide out. It can rely on stimulants from the autonomic nervous system. However, it does not need the autonomic nervous system to function. Okay, cardiac muscle, okay, runs on automaticity. It runs on its own, by its own pacemaker, all right, called the sinoatrial node. Okay, and those heart cells can generate contraction without any influence from the autonomic nervous system. Now, the autonomic nervous system can influence it, but even if that system was shut off, all right, as long as the heart's getting adequate, oxygen, glucose, and nutrients from the body, the heart will pump still on its own. It is when that oxygen becomes depleted, that those nutrients become depleted, that we run into issues with heart function. Okay, now the heart no longer generating its own impulse. So, kind of hit in on these different muscle types. Guys, just know skeletal muscle, voluntary. You have control over that. Okay, you want to flex up? Okay, skeletal muscle. You have control over that, right? Nobody's sitting in the class just flexing whenever they want. People might be thinking you're having like partial seizure at that point. So you have control over muscle contractions in your body. Those are voluntary muscles. Those are skeletal muscle. Cardiac muscles, remember, runs on automaticity. It's specialized. Doesn't necessarily rely on the autonomic nervous system. However, it can be influenced by it. Okay, runs on its own. Cardiac muscle. Smooth muscle, think, digesting food, blood vessels. All right, you guys don't think blood vessels, blood pressure. My blood pressure is high right now. Hey, blood vessels, relax a little bit. I need you to lower my blood pressure. No, it doesn't work like that, right? Okay, that's dependent on the autonomic nervous system. Okay, you don't have control over the smooth muscle. Now, moving into the respiratory system. Now, the respiratory system is responsible for respiration and ventilation. Okay, respiration is referring to the gas exchange process. So, respiration, I am bringing oxygen in, letting carbon dioxide out. I am exchanging gases within the body. That is respiration. Ventilation is the mechanical process for moving air in and out of the lungs. All right. I am ventilating right now. I am moving air in and out of the lungs. Now, that big old deep breath of air I just took, that brought in 21% oxygen in the ambient air. Okay, that oxygen traveled down my respiratory system, down into the alveoli. In the alveoli, I had oxygen enter into my bloodstream, carbon dioxide leave my bloodstream, enter into the alveoli, and I exhale. All right, that respiration, that gas exchange occurred within my lungs. Okay, so just know respiration is referring to the gas exchange process. Ventilation is the mechanical process for moving air in and out of the body. So oxygenation of blood and the removal of carbon dioxide, that is our respiration. Okay, now the respiratory system also works as a buffer to maintain an acid-base balance within our body. Okay, let's think of it like this. I have people who work out, right? You're running, you're doing a sprint, right? Okay, those muscles are working. You're in this anaerobic, exercise. You're doing that CrossFit, whatever you want to do, working hard. All right. Well, those muscles create acid, right? Because they're working hard. Okay, they're not getting adequate oxygen. You're getting acid. What's your breathing doing? Okay, well, you're starting to breathe faster. Why? Because your body is trying to maintain this acid-base balance. Okay, now we can dive extremely deep into the pathophysiology of this. What you guys need to take away of right now is, let's say our patient is becoming acidic, okay, from, common one, diabetic ketoacidosis, right? Our patient has extremely high sugar levels. However, they don't have the insulin to manage that sugar that they have. So their body starts breaking down fats as an energy source, and it creates this acidic system within the body. All right, well, those patients present a certain way. One of the things they do is they start to breathe rapid, they start to breathe fast, and they start to breathe really deep. Well, what they're trying to do is they're trying to let out that excess acid through the respiratory system. So they're breathing fast, breathing deep. All right, that is one of the ways our body works to maintain that balance. Now, for the sake of just your knowledge, your body sits blood between the 7.35 and 7.45 on the scale of 0 to 14. Closer you get to 0, it's acidic. Closer you get to 14, that's like alkaline. Okay, our body sits at 7.35 to 7.45. That's where our body wants to stay. Okay, and our body works hard to maintain that baseline. Okay, if we go out of that baseline, the body tries to compensate. Okay, and sometimes it can do it, and we're considered compensating if we can maintain that 7.35 to 7.45. But if we're outside of that, then we're decompensating. Getting a little bit deeper than we need to, but I just want you guys to kind of have an understanding of how the respiratory system works to help us. All right, now with the respiratory system, okay, kind of gross overview of our anatomy here. We have the nasal cavity. Okay, you guys have the oral Pharynx and nasopharynx. So the oral pharynx, nasopharynx, in your mouth, inside the nose. Now moving back from that, we go into the pharynx. Okay, so we go into the pharynx, oral pharynx, nasopharynx to the pharynx. Okay, moving down, we need to pass the epiglottis. Now, the posterior tube, that is moving down your esophagus. Posterior tube is your esophagus going down your stomach. Okay, the anterior tube, where we're going past this epiglottis right here, okay, that is going down through your larynx and down your trachea, okay, into your lungs. Okay, we're going to get some more closer pictures, but I'm just kind of working with what I got on this one. Okay, so your larynx is going to be where your vocal cords are housed. Okay, now that cricoid ring is the top portion of your trachea. Okay, that is what separates your upper airway from your lower airway. Okay, so the larynx up is upper airway. Okay, the trachea down is your lower airway. So from your trachea, we split it the carina. Okay, and then we go into your left and right main stems. Okay, or your left and right bronchi. Okay, from the bronchi, we go into smaller bronchioles, and then at the bronchioles, they terminate at the alveoli. Alveoli is where our gas exchange occurs. Think of this like the lower airway is like an inverted tree. Okay, your alveoli are the leaves, the smaller branches that go out to those leaves are the bronchioles. Okay, going down into your bigger branches, those are your bronchi, and then that main trunk is the trachea. Okay, well, the gas exchange only occurs at the leaves, right? Well, gas exchange only occurs in the alveoli in our body. Okay, now, with the respiratory system, here we go. This is where I just said all that stuff on that picture. Just say it all again with the words on the slide. Airway is divided into upper and lower portions, divided by the cricoid ring, the lower portion of the larynx. Okay, so if you guys see a test question and it is talking about your patient has an obstruction in the larynx, okay, the larynx, okay, he would have an obstruction in what portion of his airway? Well, the larynx is part of the upper airway, so he has an upper airway obstruction. Okay, now if there is an obstruction in the trachea, in the bronchi, in the bronchioles, in the alveoli, that is a lower airway obstruction. Okay, if it is in the larynx, the pharynx, the oropharynx, the nasopharynx, that is an upper airway obstruction. What? I knew I had a more in-depth picture here. So, moving on into this. So, we have our nose and mouth, nasopharynx, oropharynx, moving back into the pharynx here. You have this epiglottis. Now, the epiglottis here is what closes over the larynx and helps protect us from aspirating fluids and things that aren't supposed to go down the air tube from going down the air tube. Okay, so when we swallow, the larynx moves up, kind of closes that epiglottis over the larynx and provides that protection from aspiration. All right, then we move down from the larynx. Of course, that goes to our trachea. Now, the posterior tube, that is the esophagus. That is where the food goes. All right, and that moves down to the stomach. Okay, now moving on into the lower airway. So remember, we have our cricoid ring here, which is that top ring here. That is our dividing line, the cricoid ring, dividing line. Okay, so we move down. Trachea, main tube, separates into left and right main stems, or your left and right bronchi. Okay, left and right bronchi. And then we go into smaller bronchioles, okay, and then into alveoli. Big takeaway, guys, alveoli is where the gas exchange occurs. That is where we have to get the air to. So our patients with asthma that have constriction in those bronchioles and inflammation in those bronchioles, they might have air going down the trachea. They might have air going down into these bronchi. Okay, and we're constricting those smaller airways up. It's just we're not getting that adequate air. Even though we have oxygen in these areas, we cannot do gas exchange to get into the body in these areas. So what do we need to do? We need to open up those bronchioles to get air all the way down to the alveoli for that gas exchange. All right, so the lungs and the diaphragm. Okay, lungs and diaphragm, organs of respiration. So where we get our gas exchange. We have thousands of microscopic alveoli. Now, the lungs themselves, okay, the lungs themselves are surrounded by a visceral pleura. Okay, so the visceral pleura surrounds the lungs. Now, your thoracic cavity, okay, so the lining of your thoracic cavity, or think of the inside of the ribs, is lined by a parietal pleura. Okay, now there is a connection created between those linings. The space in between is called the pleural space. Okay, and that creates a suction-like effect with a semi-serous fluid that sucks that together. Okay, think of it like condensation on like a glass on like a glass countertop, when you try to pick it up and it's like that suction effect that occurs. Well, it's occurring with the lungs. So when the diaphragm contracts and pulls down, that muscle that contracts and pulls down, what is pulling the lungs down with it? When the chest wall, those muscles contract and pull the chest wall up and out, it is pulling the lungs up and out with it, opening the lungs, creating negative pressure within the lungs for air to flow in. That the pleural space and those linings are extremely important to for maintaining good volume. If we get air or blood that separates those linings, that keeps the lung from adequately inflating. Okay, so the pleural linings are extremely important. Okay, and that diaphragm, very important for breathing. The diaphragm controls 60 to 70% of our volume. Okay, so the diaphragm is definitely needed for good ventilation. All right, so with the pleural lining, so we have a visceral pleura. If you ever hear visceral, visceral is pertaining to an organ. Visceral means organ. So visceral pleura is that lining that goes around the lung itself. Okay, the parietal pleura. Parietal means wall. Parietal goes along the thoracic wall. Okay, that's inside. Now, when dealing with a normal and a constricted bronchiole. Now, a normal bronchiole, okay, that's a nice open tube, right? So when I create negative pressure, when those muscles contract, move up and out, diaphragm contracts, moves down, air can flow easily through that normal bronchiole, right? Again, moving air through a nice open tube. Now, if that tube constricts down, now it becomes harder for me to move air through it. So what does the diaphragm have to do? What do those intercostal muscles have to do that is generating that nice, opening of the chest? Those have to work harder to then pull air through that constricted opening. It has to work harder to move air through that constricted opening. So those muscles, guys, they're muscles. They get tired. I guarantee you, like, you can be the strongest person in the world. I put 100 pounds on a bench press and I just make you bench press to infinity. I don't care how strong you are, eventually you're going to get tired. Eventually you're going to get tired. Well, the same thing is going to occur here. That patient is going to be able to compensate for so long from having to breathe through this tiny tube because these muscles are having to work harder. Those muscles are going to fatigue. And no matter how hard they try, they're not going to get good contractions to get that chest open, to force air through these tiny openings, and the patient's eventually going to become hypoxic. Okay, so again, understand that breathing through that normal pipe, it's great. But when that pipe gets constricted, we have to work harder. Those muscles have to work harder, and we eventually fatigue and those muscles fail. All right, now with some of the differences between infants and children and that of adults, okay? Now, a child has a smaller nose and mouth. Okay, that makes sense, right? Because they're smaller people. Therefore, it's easier to get obstructions in those things. Not only that, but kids, especially little babies, when they get that palmar reflex, going, they grab stuff. Like, think of a little child. Like, you put your finger in that baby's hand, they do what? They grab it. They grab it, and then what do? They put it right to their mouth, because that's how those little kids explore their environment. They find out things. Can I eat this? Right? So because they have a smaller mouth and nose, those things are easily obstructed by smaller objects. Now, the tongue proportionally takes up more room in the mouth in a child and an infant than it does in that of an adult. So this is not saying that the tongue's bigger than an adult, just in regards to the size of the mouth, the tongue takes up more room in a child's mouth than that of an adult. Okay, the trachea is narrow. Okay, and the trachea, the cartilage is also less rigid. Therefore, it makes it more easily obstructed. Okay, so airway is more easily obstructed. The larynx in a child and an infant is also more funnel shaped. So you do have a higher risk of obstruction there also. Now, one thing that you need to take into account, especially with your young kids, they have larger occipital regions. And so those larger occipital regions, if you lay like a 4-year-old, for example, on a flat surface, because of the larger occipital region, they have more of a chin to chest flexion. Okay, so it's important to pad underneath the shoulders of a child less than 8 to help maintain a neutral inline position of that airway. Because you can kind of see it here. Like, look, this adult is laying flat, and you kind of have a nice straight airway there. Whereas this child's laying flat, you have a little bit of flexion here. He's an older child. It's more significant the younger you get. You have a little bit of flexion here, and that can affect maintaining a good airway also. Now, when dealing with the mechanics of ventilation. So, with ventilation, the mechanical process for moving air in and out of the lungs. Okay? You have inhalation and exhalation. Inhalation is an active process. Inhalation requires muscle contraction. To inhale, we need muscles to work to get air in. So as I inhale, diaphragm contracts, move down. Those muscles of the thorax contract, pull the chest wall up and out. That allows the lungs to open, creating negative pressure within the lungs, forcing air, or pulling air, I should say, down into our lungs to fill them. Now, when we exhale, those muscles relax. Diaphragm relaxes, moves up. Those thoracic muscles relax, move down. They compress on the lungs when they all relax. Okay, and that pushes air then out of the lungs. So inhalation, active process. Exhalation, passive process. Inhalation requires energy, requires muscle contraction. Exhalation should be a passive process, should require no energy. Now, with the physiology of respiration. Now, respiration, remember, we're referring to the gas exchange process. Now, oxygen and carbon dioxide are exchanged in the alveoli. Carbon dioxide and oxygen exchanged in the peripheral capillary beds. So we have respiration. Think of this like internal and external. Okay, so we have external respiration. That is what's occurring in the lungs. Okay, we have about 21% oxygen in the air we breathe, and a very small amount of carbon dioxide. Your textbook, 0.03% carbon dioxide in the air we breathe. I think we're getting up there. I think NASA is at like 0.04% in the air we breathe now. That's neither here nor there. Just 21% oxygen to 0.03% carbon dioxide. Okay. a lot less carbon dioxide. Now, this gas exchange process occurs through diffusion. So movement of these gases from a higher concentration to a lower concentration. All right, higher concentration to a lower concentration. So when we are in the lungs, I breathe in that 21% oxygen. That blood that is moving to the lungs has been depleted of oxygen because the body's already used it up, and there's a lower level of oxygen in that blood. So therefore, through diffusion, oxygen can enter in from the alveoli into the blood vessels. All right. Carbon dioxide, which is a byproduct of cell metabolism, which we get into later, okay, can then enter into the lungs. It can leave the blood, enter into the lungs, because the air we breathe has a lot less carbon dioxide in it, allowing me to breathe out the carbon dioxide. Now, the oxygen that I've had that entered into the blood now circulates out to the body, and that allows oxygen to then enter into the cells of the body. Carbon dioxide is, a byproduct of normal cell metabolism, can then leave the cell, enter into the blood to make its way back to the lungs again, and the whole process can repeat itself. All right. So, alveolar capillary gas exchange. This is what we're talking about. So we have oxygen. This is one alveolus. Okay. So we have the air we breathe in, 21% oxygen coming into this little alveolus. This is happening all over our lungs. Okay, oxygen coming in, 21%, high concentration. This is deoxygenated blood, been used up by the body, making its way back. Okay, so this is low on oxygen, high in carbon dioxide. Now, diffusion. High concentrations like to go to areas of low concentration. They do that easily without any effort. All right. No effort for moving from area of high concentration to area of low concentration. All right. But we are low in oxygen in this blood. We can cross over this cell membrane. Oxygen is going to come in to this blood vessel, okay, and attach itself onto a red blood cell. And now that oxygen is going to go out to the body to be used. Woohoo! It's what we want. Okay. Now this deoxygenated blood that we had was higher in carbon dioxide. We have low levels of CO2 in here. So, hey, we like to go from areas of high concentration to areas of low concentration. So that CO2 is going to hop off, and then we can exhale that CO2 when we breathe. Okay, so CO2 goes out. All right, and that's how we maintained that in our body. Now, this moves on, of course, from alveolar capillary gas exchange now to into the body. So now we're at the cells. So we have a capillary cell gas exchange. So we have just picked up all that oxygen at the lungs, right? So this blood, rich in oxygen now, it's nice and oxygenated because we just inhaled it. All right. It has low levels of CO2. Remember, because we dumped those homies in the lungs. All right. We enter now into the capillaries. And now oxygen can enter into the cell for normal aerobic cell metabolism. And that carbon dioxide that was generated through normal cell metabolism can then, hey, they're getting starting to get higher in these cells, so we're gonna drop them off. All right, we're gonna put them in the blood. All right, so oxygen is left to enter into the body cell. CO2 is entered. Now that blood is deoxygenated. We have lost the oxygen because we just dropped it off at the cells. We picked up a whole bunch of CO2 now. And now this blood is going to make its way back through the venous system to the lungs, okay, to then repeat that process, right? We're going to drop off all this CO2 that we picked up from the cells, okay, and then we're going to pick up more oxygen and we're going to repeat that process all over again. Now, the respiratory system. Now, adequate and inadequate breathing. Adequate is defined as adequate tidal volume and respiratory rate. Now, your adequate respiratory rates, this is average, is 12 to 20 for that of an adult, and then 20 to 22 more for your elderly. As we age, just body in general becomes less effective over time. Okay, so our elderly tend to breathe faster because the respiratory system isn't effective, so they need to breathe quicker to get the same amount of oxygen in. Just understand, in order to have adequate breathing, you need to have an adequate volume and you need to have an adequate rate. Okay, good tidal volume, okay, is about you see about 1 inch of chest rise in that of an adult. It is good volume. Okay, about 500 milliliters of air. Okay, is good tidal volume per breath. Now, with our kids, that gets broken down into a formula that you don't need to know. It's like milliliter of air per kilogram of body weight kind of a deal. Just understand, you want to see good chest rise because you're not going to be out there with a spirometry like, is this good tidal volume? No. Do I see good chest rise? Are my lung sounds clear? Is that patient getting good volume down to the alveoli? Okay, are they breathing at an adequate rate for their age? My patient breathing at 40, okay, is breathing too fast, okay, and they're going to be moving air simply in and out of the dead space area, which is an area where gas exchange cannot occur, like the trachea, the bronchi, the bronchioles. If I'm breathing too fast, I'm not getting air down to where I need it, okay? So obviously we're not going to have adequate breathing. If they're breathing too slow, that patient's breathing like 4 times a minute, that's not going to be good enough to get enough air down to the alveoli for gas exchange. And that's where we need to step in and intervene and then start to breathe for our patients. Okay, now moving down, our children, obviously breathing faster now, so children 18 to 37, depending on age. Infants 30 to 60 times a minute. All right, so breathing faster, the younger we get. Now, adequate breathing, regular rhythm, effortless, chest expands adequately, looking for that 1 inch chest rise. Okay, no abnormal sound, so we shouldn't have wheezing, rhonchi, crackles, none of that. Okay, lungs should be clear. Okay, and then no use of accessory muscles. So we shouldn't see the patient using abdominal muscles to force air out. We shouldn't see retractions, okay, in the neck, like supraclavicular retractions where we're retracting above the clavicles, suprasternal retractions where we're retracting in the right above the sternum. Okay, if you see retractions up there, that's letting you know that they're using muscles in their neck to try to lift the chest wall up. Okay, so like the sternocleidomastoid muscle, okay, works to lift and elevate the sternum. Now, so if you have the sternocleidomastoid muscle, the muscle in the neck, working to lift that sternum, that's where you'll see that suprasternal retraction above the suprasternal notch. Okay, if you see supraclavicular retractions where they're retracting above the clavicles, they're using those neck muscles, the scalene muscles, to help elevate ribs 1 and 2 to try to get additional volume. Okay, remember, if we're using those muscles that are not normally used for respiration, muscles fatigue. I don't care how strong you are. We don't want them to be using that. They're compensating. Eventually, those muscles fatigue, become ineffective, and then our patient no longer breathes adequately. Now, inadequate breathing. So rate is too fast or too slow. You have an irregular rhythm. Diminished or absent breath sounds. Now, this is another thing. I see it, especially like, in students where you won't hear anything. And be like, yeah, lung sounds clear. It's like, well, the lung sounds are not clear. You don't hear anything. You guys should hear something. Okay, listen on yourself. Hopefully, we're all healthy, adults taking the class. Listen to your lung sounds. That should be what they sound like. Okay, if you're not hearing anything, that's diminished. Okay, and you can have patients that have diminished lung sounds, especially if they have, lung disease, they've had sections of lobectomy where they've had sections of their lung removed. All right, just understand diminished or absent breath sounds are not normal breath sounds. Unequal or inadequate chest rise, pale or blue skin or mucous membranes, and agonal breathing. Agonal breathing is like guppy breathing, kind of look like a fish out of water, where they're just gasping. There's no rhythm to it. Okay, they just gasp for air. Okay, understand that that is not normal breathing. Okay, that is not normal breathing, and that is often seen in cardiac arrest, where patients are kind of the brain is sending a last stimulus to the body. It's like, help me now, this SOS symbol message going out to try to maintain some form of life. Okay, so we see this in cardiac arrest. Agonal breathing is not normal breathing. Now, the circulatory system. Circulatory system is a closed system to transport blood, nutrients, oxygen to all tissues of the body, and then removes any waste products from the tissue. Okay, so the circulatory system is that transport system. Now, the delivery of oxygen, glucose, nutrients to the cells and the removal of waste products is the definition of perfusion. Okay, we must have adequate perfusion to maintain life. Okay, so our body must be able to deliver oxygen, glucose, and nutrients to the cell, okay, and then eliminate the waste products created by the cell in order to maintain life. Now, the circulatory system is comprised of the heart, blood vessels, and the blood. So, we need to discuss the basic anatomy. We have the heart. It's broke up into 4 chambers. Okay, you have the atria, okay, right and left atrium. Okay, those are 2 chambers, and then the ventricles, right and left ventricles. Okay, you have cardiac valves. You have the tricuspid and bicuspid valve. Those separate your atria from your ventricles. Tricuspid is on the right side. Bicuspid is on the left side. Okay, and then you have your pulmonic and aortic valve. So pulmonic valve is what you have go from your right ventricle into the pulmonary arteries. Okay, and the aortic valve goes from the left ventricle into the aorta. What those valves do is they help prevent backflow of blood to the body. Okay, now with blood flow through the chambers of the heart, guys, you do have to, you need to be able to trace a drop of blood as it flows through the heart. Okay, a lot of words on this slide, but what we're going to do is we're going to just follow a drop of blood as it would flow through the heart and the lungs. You guys need to be able to do this forward and back. Okay, because you guys need to understand, based off the signs and symptoms you're seeing in the patient, maybe what aspect of the heart is being affected. So we'll start just, for the sake of this, in the inferior vena cava. Now, the inferior vena cava just simply brings blood from the lower extremities, okay, up to the heart, whereas the superior vena cava brings blood from the head and the upper extremities, okay, back to the heart. These are our veins, okay, so they carry these carry blood back to the heart, and majority of the time, it's veins carry deoxygenated blood, okay, but the purpose of a vein is to carry blood back to the heart, okay, and now this blood is deoxygenated. It's coming from the body. Okay, so from that inferior vena cava, remember we're just simply following one drop of blood. Okay, from the inferior vena cava, we go into the right atrium. From the right atrium, we will go through the tricuspid valve into the right ventricle. Okay, from the right ventricle, we go up through the pulmonic valve into the pulmonary trunk, okay, into the pulmonary arteries. Now, this blood is still deoxygenated at this point, but this is a pulmonary artery because arteries carry blood away from the heart. Okay, this blood is going away from the heart now. So we went from the right ventricle in through the pulmonic valve to the pulmonary trunk, pulmonary artery, okay, and let's just say left and right pulmonary artery. So left goes to the left lung, right goes to the right lung. Okay. Now these pulmonary arteries go to the lungs. Okay. They go into the pulmonary circulation. All right. So these arteries go to the lungs. Okay. These vessels now surround the alveoli, and that is where they pick up that oxygen, let out that carbon dioxide, and now make their way back to the heart via pulmonary veins. So from the lungs, our blood's oxygenated now. So this is a vein that carries oxygenated blood. The pulmonary vein will carry blood back to the heart, to the left atrium. From the left atrium, we will go through the bicuspid or mitral valve to the left ventricle. From the left ventricle, we go up through the aortic valve. Okay? And now from the aortic valve, we enter into the aorta and we pump out to the rest of the body. Now, that is how you will follow a drop of blood through the heart. Okay, you guys need to be able to do that forward and backward. All right, so understand, the flow of blood through the heart, please. It's very important. So one more time, inferior vena cava, we enter into the right atrium. From the right atrium, we go through the tricuspid valve into the right ventricle. Right ventricle, we then go up through the pulmonic valve into the pulmonary arteries to the lungs. That's where we get oxygenated. That's where we drop off carbon dioxide, is in the lungs. Okay. Now, from the lung, we come back through the pulmonary veins into the left atrium. From the left atrium, we go through the bicuspid valve, okay, into the left ventricle. From the left ventricle, we go up to the aortic semilunar valve, okay, into the aorta, and then out to the rest of the body. Now, that's us sending oxygenated blood out to the rest of the body for cell metabolism. All right, guys. Make sure you know that, know it by heart. Trust me, if you guys are able to do it now, it's going to help you so much when we get into, our respiratory and cardiac emergencies. So to work on this, guys, take, a picture of the heart. Like, there are plenty that you can Google online and like blank out the words to it and drop your, be able to identify the different parts of the heart, but then also be able to follow blood as it goes through the heart. Now, with our basic anatomy of the circulatory system, okay, so we have our arteries. Arteries carry blood away from the heart, away from the heart. So we have the aortic artery, coronary arteries. Coronary arteries are the arteries that perfuse the heart muscle itself, okay? So coronary arteries perfuse the heart muscle itself, and that is actually the first stop for our blood after it leaves the heart. Heart's selfish. It gives itself the blood first, okay, is the coronary arteries. Now we have the carotid arteries, which carry that blood up to the brain, okay? We have our femoral arteries, which carry the blood down to our lower extremities, okay? And we have the arteries of the arms, okay, and the arteries of the legs, okay, such as the popliteal artery behind the knee, the radial artery of the arm brings blood, oxygenated blood, down to the lower extremities, down to the upper extremities for those muscles, those cells to function. Okay, now with our coronary arteries, guys, please understand this. Now, with the aorta, so remember we leave the left ventricle, go up through the aortic semilunar valve into the aorta. Now, these coronary arteries branch off of that first starting point of the aorta. Why? Because the heart is selfish and it wants that oxygen first. Okay. Now, the left coronary artery perfuses the left side of the heart with good oxygenated blood. So we give oxygen and nutrients to the left side of the heart, okay, from the left coronary artery. Okay, the right coronary artery perfuses the right side of the heart. Now, from the left coronary artery, we have the anterior descending branch. Okay, that is going to perfuse the left ventricle specifically. Now, off the left coronary artery, it's not labeled here, but you have the circumflex artery, and that actually wraps around the back of the heart and perfuses the posterior aspect of the heart. Okay, it's not labeled here, but it is there, and that's where that portion of the heart gets its oxygen nutrients from, is a circumflex artery. Okay, what you guys need to know is, these vessels can get occluded over time. Stress hormones, increased cholesterol and fat in the vessels, eventually causes these to fill with plaque, atherosclerosis. They get stiff, full of gunk, and they can start to occlude over time. And that is when our patient gets put at risk for heart attack. Okay, so when that artery becomes completely occluded, oxygenated blood can't flow through it anymore. This area beyond wherever the occlusion is dies, and our patient experiences that chest pain. Okay, so the heart is greatly dependent on these coronary vessels to be, patent open and having that good oxygenated blood flowing through it for the heart to function adequately. Now, with our capillary beds. So capillary beds connect arterioles to venules. That is the level where gas exchange will occur inside of the body. Okay, so that cellular gas exchange, that cellular respiration that we talked about, it occurs at the capillaries. Why? Because they're single-walled, okay, and they allow for that diffusion of those nutrients and gases to occur. Now, the venous system, this houses actually the most of our blood. So about 64% of our blood is housed in the venous system at any one point in time. All right. The veins are responsible for bringing blood back to the heart. Do not get sucked into arteries carry oxygen and veins carry deoxygenated blood. Why? Because it's not always true. We know that now from the heart, right? Pulmonary arteries carry deoxygenated blood, but they carry blood away from the heart. That's why they're called arteries. The pulmonary vein carries oxygenated blood back to the heart. Okay, it's a vein because it carries blood back to the heart, even though in pulmonary vein it's oxygenated. So venous system, 64% of our blood at any one time is in the venous system. Now, venules are the smaller veins that branch from capillaries. From that, we move into bigger veins. Now, the vena cava is the large or the great vein, okay, that is responsible for carrying blood back to the heart, inferior from lower extremities, okay, and the superior from the head and upper extremities. Okay, and then the pulmonary veins carry blood from the lungs back to the heart itself. Now, not a lot with this slide, just kind of showing you guys we have arteries, we have veins, we have capillaries, we have heart. What I want you guys to note here, if you can, it's a small picture, and if you're looking on a phone, it's probably even harder to see. But with the veins, I want you to note that they have these valves in them. Well, the valves are present because veins are low pressure. Okay, arteries are high pressure, veins are low pressure. Valves are present in the veins in order to prevent the backflow of blood. If those valves were present, we'd have a lot of blood pulling in areas, especially when we have gravity working against us. Okay, so in the veins, we have these valves present because they need to be there to keep blood from flowing backwards, because valves are low pressure vessels. Okay, here we go. Here's that bigger picture. Now, also note here the muscle that surrounds artery is greater than that in artery than a vein. Okay, and then I want you to take away here the single-walled endothelial tissue, okay, is what allows for gas exchange to occur in only the capillaries and not in the arteries or the veins, okay? Why? Because this is single-layered endothelial, where this has many layers, therefore it does not allow gas exchange to occur through them. All right, now when dealing with the heart's cardiac conduction system. So the cardiac conduction system, we talked about the heart running on automaticity, runs on its own, does not need the brain. It's like, I can do this, I'm independent, I don't need your brain. Okay, the heart can work on its own. It does that through the sinoatrial node. That is the heart's primary pacemaker site. Okay, located here in the superior aspect of the right atrium. Now, the sinoatrial node is the heart's primary pacemaker, and it sends impulses down to the heart to generate a rate between 60 to 100 beats per minute. Okay, so primary pacemaker is the sinoatrial node. The heart, that is how the heart generates its own impulses. It's through this. Now you have these internodal pathways here, deliver those impulses to the atrioventricular node. Now, if say there is damage to the heart sinoatrial node and the heart is relying solely on the AV or atrioventricular node by itself, the AV node can generate a rate between 40 to 60 beats per minute. Okay, 40 to 60 beats per minute if the sinoatrial node is damaged. So you see how like we got some systems in place to, it's like, man, well, if the primary pacemaker's down, kind of got a secondary pacemaker that's able to generate, it's a slower rate, but we can at least get some beats in. You know what I'm saying? So we can generate that at the atrioventricular node. Now, from the atrioventricular node, we go through the bundle of His, which is a bundle of nerves, and we separate into left and right bundle branches. So from the left bundle branch, we go out, and then we have all these smaller nerve fibers that will innervate the ventricular muscles. Okay, on the left side, it's the Purkinje fibers are what innervate at the end of our branches. Okay, now, understanding of the left and right bundle branches. These go out and terminate in Purkinje fibers. Not labeled here, but you have the Bachman's branch that branches off over here to the left atrium. Now it assists with like an atrial kick. Real quick, not to get too like deep into the weeds here, but our heartbeats in like a lub dub. Okay, lub dub, lub dub, lub dub. That sound you hear isn't the muscles contracting; it's the valves, opening and closing. Okay, but what allows the ventricles to fill here isn't so much like the atria pumping and pushing blood into the ventricles. It's when the ventricles relax, they fill with blood, and it opens these valves up to allow blood to flow in. And then you have an atrial kick, that little extra contraction from the atrial muscle that gives an extra volume into the ventricles. Okay, I feel like I'm confusing now, but just understand it's more of a negative pressure that allows the ventricles to fill with blood versus an atrial contraction that fills the ventricles. So we have negative pressure. Those ventricles need to relax in order to fill adequately with blood versus the atria contracting and pushing blood in. That's why patients with junctional rhythms, that remember the atrial node, we talked about that. That's why those patients can still technically be, they still be awake and everything, even though like there's no stimulus coming from the sinoatrial node. Okay, there's no contraction of the atria here. Well, it's because the heart can still fill itself if you get adequate negative pressure, so blood can flow into the ventricles. Now, kind of went down a rabbit hole there. What you guys need to understand: sinoatrial node, heart's primary pacemaker. We go through internodal pathways to the atrioventricular node. Secondary pacemaker site, able to generate a rate between 40 to 60 beats per minute. You go down the bundle of His to our left and right bundle branches, okay, and they terminate out to the Purkinje fibers. Now, if the Purkinje fibers are all we have that is generating impulses, okay, that is a bad thing because Purkinje fibers don't coordinate together, they don't work together, they just fire off on their own, okay, and they cause fibrillation of the heart. Okay, now if we have ventricular fibrillation, that is a cardiac arrest rhythm. The heart cannot function with impulses generated from the Purkinje fibers. That is one where we need to shock the heart and provide CPR on the patient. Okay, that is what you need to know from this slide. Okay, sorry I went down a rabbit hole there, but spinal atrial node, primary pacemaker, atrioventricular node, secondary pacemaker site. Okay, now the circulatory system. We have composition of our blood. We have red blood cells, white blood cells, platelets, and plasma. Now our red blood cells do things like carry oxygen, carry carbon dioxide. Okay, our white blood cells do things like fight infection. Okay, our platelets help us create good blood clots. Okay, and our plasma is what suspends our red blood cells, white blood cells, platelets, and has our blood proteins in it. So with the physiology of circulation, we assess the pulse and blood pressure that gives us information about the adequacy of circulation. So we need a good blood pressure in order to adequately perfuse all of the cells of our body. Now, when we have a pulse, okay, that is created by a wave of blood that is generated from contraction of the left ventricle. So if you feel for the radial pulse, every time you feel that little beat, okay, that is your ventricle contracting, pushing blood out to the artery, and that wave of blood going down through those vessels. Okay, so that is a pulse. Now, if we have issues with circulation, say we're losing blood volume, or our patient's heart is not functioning adequately, well, we start to lose pressure. Okay, and with that pressure that we start to lose, we also start to lose, those distal pulses. So those distal pulses start to go away. Oh, we might need to go more proximal to assess and find that pulse. Now, when dealing with pulses, our central pulses are going to be our carotid and femoral pulses. So the femoral pulse is actually palpated in the inguinal region. Okay, carotid pulse located on the left and right side of the neck. Okay, peripheral pulses are going to be our radial pulse, felt on the thumb side of the distal radius. Okay, you have the brachial pulse, which can be palpated on the medial portion of the upper arm in between the bicep and the tricep muscle. Okay, you have the posterior tibial pulse, which is palpated on the medial portion of the ankle bone, okay, or the tibial malleolus. So if you feel that, if you look at your ankle, you have that nice little ankle bone. Okay, it's the malleolus of the tibia. Okay, if you go just behind that ankle bone, okay, you should be able to feel the posterior tibial pulse. Okay, and then the dorsalis pedis pulse, dorsal, remember, pertaining to the back. For our foot, that's the top of the foot. Dorsalis pedis is a pulse that is felt on the top of the foot. Now, with blood pressure is a force exerted on the walls of the artery as blood passes through it. Now, your systolic blood pressure represents the pressure in the arteries when the heart contracts. Your diastolic pressure represents the pressure in the arteries when the ventricle is at rest. That's why the top number is always going to be higher than the bottom numbers because, well, the heart has to generate more force than what we have pressure in the vessels. So systolic blood pressure, pressure of the vessel, okay, pressure on the arteries specifically when the left ventricle contracts. Diastolic pressure represents the pressure in the arteries when the ventricle is at rest. Now, hydrostatic pressure is the force of fluid within the blood vessel and is determined by the volume of blood. So let's say we have a patient who has increased fluid in their body. We can see this with patients who have fluid overload, like patients with kidney failure, patients with congestive heart failure. They have issues with fluid overload. Okay, so they have too much fluid in the vessels. What that means is we have excess pressure from fluid being exerted on our vessels. Now, elevated hydrostatic pressure can be detrimental. So let's say we have a heart failure patient, okay, and they have fluid overload and they have increased hydrostatic pressure. Well, let's say we'll go with left-sided heart failure. Now, if you can follow that drop of blood through the heart, if we go from the left ventricle backward, from the left ventricle we go up, we're going backwards now. Left ventricle, we're going backwards. So left ventricle, we go through the bicuspid valve, backwards to the left atrium. Left atrium, we back up to where? The lungs. So let's say we have increased pressure from fluid overload in the lungs because of left-sided heart failure. Well, as that pressure increases, hydrostatic pressure is going to force fluid out of the vessels. And patients with left-sided heart failure can end up having what we call pulmonary edema or fluid buildup in the lungs because the left side of the heart's filling, increasing fluid pressure in the lungs, in those surrounding blood vessels. And that can cause issues with gas exchange and the oxygenation of our patient. That is the downside of increased hydrostatic pressure. So, with this, now we have effects of hydrostatic pressure. So, more fluid that we have building up in the system forces fluid out. Not only does it force fluid out, but it forces blood proteins out. Now, blood proteins will pull fluid with it. All right, and so that pulls more fluid out of the vessel into the interstitial space, which leads to worsening pulmonary edema if we're talking about the lungs per se. Now, with the physiology of circulation, we have perfusion and hypoperfusion. So perfusion, kind of hit on this already, but the delivery of oxygen, glucose, and other nutrients to the cell and the elimination of waste products. Now, hypo simply means low. So hypoperfusion, low delivery of oxygen, glucose, nutrients to the cell, and low elimination of the waste products. Think of hypoperfusion, think of shock. Okay, so the patient is not getting what they need to the body. They are, in a shock state at that point. So here's just another little overview of the circulatory system and tissue perfusion. Okay, so we'll dive into blood flow to the heart one more time. So coming up through let's go inferior vena cava, we enter into the right atrium. Right atrium, we go through the tricuspid valve into the right ventricle. Right ventricle, we go up through the pulmonic valve to the pulmonic arteries and out to the lungs. Remember all that blood that we had? It was deoxygenated, right? So we're going to the lungs. We got a bunch of CO2 we need to drop off in the lungs. So we drop CO2 off. We pick up that oxygen because our patient's breathing great. Pick up that oxygen, and now we're coming back. All right, coming back through those pulmonary veins into the left atrium, through the bicuspid valve, into the left ventricle. From the left ventricle, we go up through the aortic semilunar valve into the aorta. Now, where is that first stop for blood once we hit the aorta? Where do we perfuse first? The heart itself, the coronary arteries. All right, so we're perfusing the heart muscle because we like to keep the heart happy. All right, and then we go out to the rest of the body. We got that oxygenated blood continuing on, going out to the cells of our body to be used for cellular metabolism, guys. We drop off oxygen to the cells, we pick up CO2 created by the cells, and then we repeat the process all over again. All right, now, guys should hope you guys practice this, be able to do it, okay? Because it's going to greatly help you guys, with future lectures. We hit on this every lecture, but better understanding you have now, the easier it'll be, when we're hitting those other topics. Now, with the transport of gases in the blood, now 97% of oxygen is carried attached to the hemoglobin. 3% of oxygen is dissolved in the plasma to be carried by the plasma. Now, what this is telling you is our body relies heavily on hemoglobin to transport oxygen throughout it. So if we have a patient with, say, anemia or blood loss where they're losing the red blood cells, the hemoglobin, we are not going to be able to adequately transport oxygen to the cells of the body and get our body what it needs. Now, with carbon dioxide, 70% of carbon dioxide is carried in plasma in the form of a bicarbonate. 23% of carbon dioxide is attached to the hemoglobin, and 7% of carbon dioxide is dissolved into the plasma. Now, we get into this more in pathophysiology, but guys, what I want you guys to think about with carbon dioxide now is think of carbon dioxide as an acid in the body. So if we increase carbon dioxide, we increase acidity in the body. So if a patient's not breathing adequately, they end up increasing CO2 in the body and they become acidic. Okay. Now, counter to that, they're breathing too fast, they let too much CO2 out, they can become alkalonic. So, understand this is how CO2 gets transported throughout the body. Now, the issue here is just you have this conversion of our CO2 when it enters into the blood into carbonic acid. So, you need to think of CO2 in a sense as an acid. Now, we have transport of gases in the blood and cell metabolism. So normal metabolism is aerobic metabolism, okay? Aerobic metabolism allows us to generate lots of energy to be used by the cell in the form of ATP. Now, the first steps of cell metabolism is an anaerobic process, but we add oxygen. Oxygen is what makes it aerobic. We add oxygen in order to kind of increase the chemical reaction within the cell to create more energy. Understand if we remain in an anaerobic state, anaerobic, that AN prefix just means without. If we stay in an anaerobic state, we create less energy. Okay, and then we also have some nasty byproducts that get created with anaerobic metabolism. So, moving on with the nervous system. So, functions. Now, the nervous system controls and maintains a state of awareness. Okay, transmits sensory and stimuli to the brain, controls voluntary and involuntary motor function, and then controls body function through autonomic nervous system function. All right, so nervous system, we got control, okay, with the nervous system. Now we have this, conscious control and, unconscious or subconscious control. Now there are things that happen that you're not, necessarily like, I need my blood vessels to maintain a certain vessel tone right now, or I'm going to pass out. You're not thinking about that. That's autonomic, guys. Whereas voluntary function, like me talking here, me clicking next slide, probably before you guys are ready for me to click next slide, that is voluntary. It's voluntary not because I want to move fast, but it's voluntary because, hey, got to go to the next slide, right? Now, we also get sensory stimuli, to the brain. We have receptors everywhere. Receptors, they receive messages. Thermoreceptors receive messages about, our atmospheric temperature from our environment. I'm hot in this room. What happens? Hey, thermoreceptors are like, bro, hey, it's hot in this room. Sends that message up to the brain. Okay, hypothalamus, works to regulate temperature. Hypothalamus is going to be like, hey, thermoreceptors are saying it's hot. You know what I need to do? It's like we need to cool the body down a little bit. So The hypothalamus is going to send that message out to the body now. It's like, hey, thermoreceptor said it's hot. I agree it's hot. All right, hey, I need you to start sweating right now to cool the body down. Okay, so what happens? I start to sweat. What about when I get cold? Thermoreceptors pick up on cold. Ooh, brr, right? Okay, thermoreceptor pick up on cold, send it to the hypothalamus. Hypothalamus in the brain's like, man, it's cold. What do we need to do? All right, hey, well, let's go ahead and create some goosebumps. Make the hair stand up. See if we can trap more heat closer to his body. Hey, let's make him shiver because it's cold. The shivering is how we generate heat. Boom, shiver. And I start to shiver now. All right, there we go. That's how we work with stimulus from the brain and receptors of our body. We have lots of different receptors. Baroreceptors measure pressure. Chemoreceptors measure acid levels and oxygen levels in our body. Okay, and they all work together in this system to maintain a balance. Now, with structural divisions of the nervous system, the central nervous system consists of the brain and spinal cord. Okay, peripheral nervous system, okay, is all peripheral nerves that branch off of the central nervous system. Now, with the nervous system, we are going to very quickly go over this. You have the cerebrum. Now, the cerebrum is the larger aspect of the brain here. It's broken up into different lobes. All right. Again, we don't dive that deep. I think it's like a paragraph in this chapter, but with the cerebrum, okay, and the different lobes. Frontal lobe, okay, guys, I want you to think like emotions. Think about higher level thought, higher level thinking, okay, behavior. Our parietal lobes, that's going to where we have process of our motor and sensory functions. So that's the areas of the brain that are going to receive stimulus from the body. Okay, hey, now send a message back out to carry out appropriate action. Okay, the occipital lobe back here in the back, that is going to be playing a role in like vision, okay, and what we're seeing and processing vision. Now there's more that goes into it, guys. Like Wernicke and Broca area with expressive and receptive speech. With the cerebrum, all that happens up in the brain, but we just don't dive into that here. Okay, now the cerebellum, okay, this aspect that sits just inferior to the cerebrum here, that is going to regulate and control your balance and control steady motion. All right, so if a patient has cerebellar damage, they're going to have issues like with walking and balance. They'll have like an unsteady gait. Let's say if I had cerebellar damage, like me sitting here right now, I have my phone out in front of me to the left. If I wanted to grab my phone and click and see, hey, do I have any text messages? All right. Well, there's some kind of semi-fine motor skills that are involved there of pressing that little button. If I had cerebellar damage, well, that nice coordinated movement of even pushing that button would be extremely difficult because the cerebellum is what helps me coordinate and work in that smooth motion to hit those buttons on my phone. Okay. Now we have the medulla, okay, or the brainstem in a sense. Now with the brainstem and the medulla, guys, you need to look at that as controlling our brain's most primitive function. Now in that brainstem is where you're going to have the cardiac center. Okay, that's where we're going to be sending messages from our brain to the heart to, hey, we need to beat a little bit faster. We need to increase force of contraction. Okay, the respiratory center. We have a ventral and dorsal respiratory group that receives information from receptors, like chemoreceptors and stretch receptors and irritant receptors. Okay, we have that dorsal respiratory group that receives all this information, and the ventral respiratory group that, hey, sends messages out to the respiratory system to maybe increase or decrease the volume of our breaths. Okay, but it's all controlled in the respiratory center in the brainstem. Okay, we have the vasomotor center in our brainstem that helps us regulate adequate vessel tone. The big takeaway, guys, is if the brainstem is damaged, okay, you can think of this as like the on-off switch for the body. Okay, so if we have damage to the brainstem, it's in a sense going to stop all essential autonomic function. Okay, and quickly lead to death. Now, moving on here, this is showing you guys afferent and efferent nerves and a reflex arc. Now, what this is like, remember how I talked about the cerebellum, or sorry, the cerebrum. Okay, I talked about the cerebrum and controlling, motor sensory function. Like, I think I want to grab my cup of coffee, I go out and I grab it and I take a sip of my coffee and I put it back down. Right, that all that movement, that process is going through my cerebrum. Now, if I come across something like this, where I go out and I grab my cup of hot coffee and my wife put it in the microwave, say, for freaking 5-10 minutes because I want to have a hot cup of coffee. And I go and I touch that cup and it is boiling, burning hot, right? Well, that message isn't going to go all the way to my brain initially. What's going to happen is this message is going to go right to my spinal cord, and in a reflex arc, it is going to send a message to my motor neurons to show, oh my gosh, pull that arm away now, right? Now, these messages get sent extremely fast, but what it does is it helps protect us from injury. Okay. Now it is like I go, ooh, and I pull back, and then I think to myself, in my brain, it's like, that was hot. Maybe I should let it just chill for a minute before I touch it again. So again, hitting on the reflex arc here. Now, with functional divisions of the nervous system, voluntary nervous system, remember, we have control over this. We have control. Grab my coffee, messing with my phone, talking like a madman. Whatever's going on, I have control over it, right? Now, we have the autonomic nervous system. And now this branches off into the sympathetic and parasympathetic nervous system. Now, sympathetic nervous system, think of this as your fight or flight center of the nervous system. All right, so fight or flight. Now, when the sympathetic nervous system is stimulated, you guys can think of this as like the body's way of like, oh my gosh, I'm about to fight a bear, or oh my God, I'm about to run for my life. So certain things are going to happen in the body when we're getting sympathetic stimulation. Okay, this is automatic. So I'm going to try to relate this to something that probably everybody has experienced at one point in their life. Maybe a near traffic collision, okay, where somebody in front of you slammed on their brakes and you have to slam on your brakes and you have this, oh my gosh, something is happening. All right. Or another one. Public speaking is a great one because people hate public speaking. All right. The body is going to trigger certain responses when you have this happen. So let's stay with the motor vehicle crash. You slam on your brakes, right? What do you feel? Okay. What do you feel when that happens? Your heart's probably pounding 100 miles an hour, right? Palms start to get a little sweaty. Mouth starts to feel a little dry. Okay. Pupils are huge. All right. Now, why is that happening? Why heart's pounding 100 miles an hour? Because it wants to get oxygen out to those muscles, ready to react, ready to run, ready to fight, whatever it needs to do. Pupils dilate big. Why? To allow more light to come in, to gain visual acuity. Okay? Are we worried about digesting food in that, oh my gosh, moment? No, we're not. So we decrease saliva production. We decrease peristalsis in the stomach. We do those things. Why? To focus energy elsewhere. Again, anybody's ever been public speaking before, get that dry mouth and you're like, why is this happening? I'm drinking plenty of water. It's like, well, you might be nervous as all get out and your body's just getting a sympathetic response to that. Okay. What happens? Breathing starts to get faster. It's like, why? Because the body needs to get more oxygen in, right? It's preparing for that fight or flight. Now, parasympathetic, boom, think of the counter to that, okay? Think of the switch. Hey, brings everything back down. Biggest parasympathetic stimulation in the body is what? Watching television. You just sit there and it's like, bah, you go brain dead, right? And you watch TV, all right? Now, everything mellows back down with parasympathetic stimulation, okay? Heart rate slows down. Blood vessels relax. increase in saliva production, increase in peristalsis. That's why sitting down and watching TV and eating is a bad thing, because you'll like mow through a giant bag of Doritos in like no time. All right, sitting down watching TV. Why? Because your body's like, hey, this is rest and digest, baby. Let's process this food. Keep putting her in there. All right. So those are autonomic reactions to external stimulus. All right. And we would use this again to create a balance and then to also react to our environment. So this is kind of hitting on the different signs and symptoms that you can see with sympathetic versus parasympathetic stimulation. Now, with your direct nerve stimulation, I want to hit more on the sympathetic because this is what we see for cases of shock. All right, say we have a patient that is bleeding out, all right, from like a gunshot wound, in the leg and in the arm. They're bleeding out, right? Well, their body goes into this fight or flight response, and it does this to keep them alive. So the body senses like, oh my gosh, I've been shot. Boom, I need to react to this. All right, so blood vessels constrict. Okay, blood vessels constrict, our heart rate increases. Okay, and then not only that, that direct nerve stimulation is also going to trigger the adrenal glands to release epinephrine. Epinephrine is going to help give us hormones to give us a prolonged sympathetic nervous system response. Okay, it's going to release that adrenaline. I can tell you, like I've had multiple shooting patients that have come in, all of them been extremely diaphoretic. Well, that's happening because of nervous system response, guys. I mean, their pressures were great, but their body is getting this fight or flight response, so they're diaphoretic head to toe. All right. Now, other things that occur with sympathetic nervous system activity is we see decrease in peristalsis. So we're not worried about processing food. We see decrease in saliva production. Okay, the patient gets dry mouth. That's where they're like, I want something to drink. Give me water. Okay, I've had multiple shootings, brought into the ER recently, and all of them are like, give me water. I need water. My mouth's dry. Okay, again, it's that sympathetic nervous system response, guys. Now, our body is going to get more glucose into it. All right. Why? Because it's going to allow our cells to function, because we want to increase glucose in the body. So we decrease insulin release with sympathetic nervous system stimulation. Raise our sugar levels because we need the sugars. All right. And then parasympathetic, again, that's just that balance. Okay. So parasympathetic is what's going to bring us back down to baseline. Pupils will constrict, increase saliva production. Okay, our heart rate will slow down, blood vessels will relax. We increase peristalsis and gastric secretions. Okay, so that's that rest and digest, where sympathetic is that fight or flight. Now, consciousness and unconsciousness. Now, this relies on the cerebral hemispheres and the reticular activating system. Now, the reticular activating system isn't necessarily a system, it is just a bundle of nerves in the brainstem. Now, the reticular activating system needs to be functioning in order to have a level of consciousness. Okay, we need at least one cerebral hemisphere and the reticular activating system to be functioning. All right. If both hemispheres are down, okay, we're going to be unconscious. Okay. If we have, both hemispheres functioning, but the reticular activating system has been damaged, our patient is going to be unconscious. Okay. So this just gets into the reticular activating system, what we need in order to remain conscious versus unconscious. So reticular activating system needs to work in at least one cerebral hemisphere in order to remain in a conscious state. Now, the endocrine system. Now, this is made up of ductless glands that secrete hormones to regulate body function. So we have different hormones carry out different functions, and these hormones work to maintain a balance within our body. So we have different endocrine glands. Okay, we have the pineal gland, that is what helps regulate our like sleep-wake cycle. All right, so in a sense, your circadian rhythm. So when you're, lights, that's why, heavily reactive to our environment and the lights. It gets dark, you feel tired. Okay, well, that is that gland activated, and hey, it's time to sleep. Okay, the thyroid and parathyroid gland. Now, the thyroid gland works to regulate metabolism. Okay, whereas the parathyroid gland works to regulate your calcium levels within the body. Okay. Adrenal glands. Now, adrenal glands sit atop the kidneys. Now, the adrenal glands work to release epinephrine and norepinephrine. Okay, now with epinephrine and norepinephrine, that helps sustain our sympathetic nervous system response. Okay, now our gonads, ovaries, and testes. Now, those are our primary sex organs, or the ovaries and the testes, and they release your sex hormones. Now, the one thing I will say is uh, those sex hormones are, depending on the the brain and that master gland or the pituitary gland to release things like follicle stimulating hormone and luteinizing hormone and gonadotropic releasing hormone in order to, uh, you know, again, kind of pituitary glands, that master gland, in order to send hormones down to the testes and the ovaries to release their hormones. So the hormones for the gonads, for the ovaries, is estrogen and progesterone, and for the testes is testosterone. Now, the islet of Langerhans is within the pancreas, okay, and that is what is responsible for the endocrine functions of the pancreas, and that's going to release, you know, different cells are going to release things like uh, insulin and glucagon. Now you have the pituitary gland, again, the master gland in a sense. You have the anterior pituitary gland, which works to release things like, follicle stimulating hormone, luteinizing hormone, gonad releasing hormone. And then you have the posterior pituitary gland, which releases antidiuretic hormone, and then like oxytocin. All right. And then you have the thymus gland, which actually shrinks with age, but that is going to work to, in a sense, train your white blood cells or your T cells as part of an immune system response. Okay, so you can think of the thymus gland as like a training center for your immune system, and it creates T cells, which the thymus again gets smaller with age. Okay, now with the endocrine system, epinephrine and norepinephrines are the big ones that we focus on for this text because it's responsible for a lot of the signs and symptoms we see with hypoperfusion. So epinephrine is adrenaline. Okay, norepinephrine are secreted by the adrenal glands, which sit atop the kidneys. Okay, and they produce the signs and symptoms that you see with sympathetic nervous system stimulation. Now we have four basic effects. Okay, and these come from different areas of epinephrine. Okay, so we have the alpha 1 response. So alpha 1 is responsible for activation of sweat glands. Okay, we have um, activation of sweat glands, and we have vasoconstriction are the primary things that you see with the alpha 1 response. So sweat glands get activated and vasoconstriction occurs. Alpha 2 regulates the effects of alpha 1. Alpha 2 also plays a role in insulin sensitivity, so it decreases the efficacy of insulin when adrenaline is being dumped into the system. Okay, beta 1 plays a role on the heart, so it increases cardiac contraction, the force of cardiac contraction, and increases our heart rate. Beta 2 affects the lungs, so beta 2 plays a role to dilate the bronchioles to ease the flow of air into the lungs and the alveoli for gas exchange. Now, norepinephrine has more effects on alpha 1, alpha 2, with trace effects of beta 1, beta 2. So, norepinephrine we actually use a lot in the hospital to help patients maintain vessel tone. Okay, but we don't see significant effects on the heart and the lungs with norepinephrine versus giving a patient, epinephrine will, increase heart rate and increase vessel tone. So epinephrine has all of these effects, whereas norepinephrine has more of the alpha effects. Now, the integumentary system, that is the skin. Okay, so the skin. Now, with the skin, it provides that protection. So it creates a nice tight seal all over the place and protects us from the environment. Okay, it helps us regulate a core temperature. So we can, sweat to help cool off. We can have piloerection, that's where the hair that we have on our body stands up. And the purpose of that is to actually, the goosebumps is to trap air closer to the body so we can warm that air and try to stay warm in that way. Also, the blood vessels in the skin can constrict and relax. We constrict if we want to maintain and keep warm temperature in. We dilate and relax to allow more blood to the surface of the skin to cool off via radiation. Okay, it serves as a receptor of external stimuli. So we talked a little bit about thermoreception, but also pain reception. Okay, so if I get that touch from pain receptors, I get that reflex arc to, hey, pull away. That burns. I don't like that. Pull away from it. Okay, and it also aids in the regulation of water and electrolytes. So, we sweat, we release and lose fluid, and we lose electrolytes. Now we have different layers of the skin. We have the epidermis, the dermis, and the subcutaneous tissue. So the epidermis is the outermost layer. Now the outermost layer of the outermost layer is actually comprised of a lot of dead skin cells. So we slough off that top layer of the epidermis constantly, and we're generating new skin cells. Now, within the dermis, we have lots of different things going on. So we have smaller blood vessels, we have hair follicles, we have sebaceous glands, okay? We have nerve endings that are in the dermis, okay? We also have below that the subcutaneous tissue, which is comprised of larger blood vessels and adipose tissue or fat. Now, our adipose tissue or subcutaneous layer varies in thickness depending on location. So, my eyelid is going to have less subcutaneous tissue than, say, my abdomen. All right, so that varies in thickness based on location. Now, the one thing to take away here with, like, say, the dermis, for example, is like those receptors. So the receptors are located, different levels in the dermis, but you can have pain receptors, like say where patients received a, full, thickness burn, and they've burned all the way through their dermis. Well, that patient with that, in a sense, that full thickness burn might not feel any pain at the site of the burn because they've burned through the nerve ending entirely. And the only pain they're getting is from the surrounding, superficial burns. Now, the digestive system, that consists of the alimentary tract and accessory organs. Now, the function is to ingest and allow absorption of nutrients and eliminate waste products. So digestive system, this is going to be pretty much everything from us chewing up our food to defecating it out into the toilet. All right. Okay, now with the digestive system and its structure. Okay, so let's start with chewing up our food in our mouth. So you eat a bite of pizza and you start chewing it up. It works with saliva to create this bolus of food that you swallowed, goes down your esophagus, enters into the stomach. Now in the stomach, you're going to get stomach acids that work to break down that food even more. We want to break this food into its simplest form or its monomers in order to be absorbed into the body. Okay, we need to be able to absorb it in its simplest form. All right, so the stomach works to play a role to break that down. Additionally, once we leave the stomach into the duodenum, okay, the pancreas plays a role with exocrine functions. So we talked about endocrine functions of the pancreas. Now we have exocrine functions of the pancreas. We have enzymes that get released like protease, breaks down proteins. Lipase helps us break down fats. Okay, these enzymes work to break down the foods more. Now, fats are a tough one. Fats are big. Okay, so we need assistance with breaking down our fats, and that's where we rely on the liver and gallbladder. So liver cells create bile that gets stored in a very high concentration in the gallbladder. Now, when we eat fatty food, the gallbladder will contract and release this bile into the through the pancreas into the small intestines to help us break down those lipids, okay, into their simple forms, right? So that's the role of the gallbladder and the liver with digestion. Now the spleen does not, even though it's located in the digestive tract, okay, like in that area in the abdomen, you can think of like the spleen as like an oil filter for your car. It works to clean the blood. All right, now with the small and large intestines, so we have the duodenum, the jejunum, and the ileum are the different portions of your small intestines. Now, as we have what we call chyme, that is that broken down food that's being moved through the digestional tract, okay, and nutrients are being absorbed, okay, throughout that whole tract. Now, as we go from the small intestines into the large intestines are going to be responsible for a lot of the fluid reabsorption, so we're not losing excess amounts of fluid. Okay, and that's what helps us form feces. So if we have, say, a patient with like diarrhea, well, what could be occurring there is the body is trying to expel whatever it's consumed. And so the large intestines are not reabsorbing the fluid because the body wants to get rid of what is in it. Okay. Now the rectum and the anus, that is, our last stop in a sense before we defecate into the toilet and let out that food. All right. So that is kind of the process and the different structures and their function. Now, with the digestive process, we have two processes. We have mechanical digestion, which we talked about us actually chewing up our food, and peristalsis, kind of moving the food down its tract, and then the chemical digestion of food, which is through enzymes and bile to break food down into its simpler form. Remember, we need it to be broken down into its simplest form in order to be absorbed and to use the nutrients from it. All right, the urinary system. Now we don't, again, it's like a chapter in your book, but the urinary system is super important because it plays a huge role in like maintaining electrolyte levels, excreting waste. Okay, it even plays a role in if our sugar levels get high, we start to urinate out high, excess sugar. Okay, so the urinary system is extremely important, but it consists of kidneys, ureters, urinary bladder, and then from the bladder, your urethra. Now, with the urinary and renal system, now the kidneys are it's like another filter for the blood. And the kidneys also play a role in managing a pH level of your blood. So they can let out hydrogen ions if we are getting acidic and help maintain a bicarbonate in order to provide a buffer system to keep us at an adequate pH. However, this system takes longer in the kidneys and it's not as effective as, say, the respiratory system to work in emergencies. So this is added. I added this on here to show you guys. We have the glomerulus. Now, this is actually like the filter system within the nephron or a kidney cell. All right, and you have like these small loops, okay, like the proximal loop, the loop of Henle, the distal loop. You don't need to like dive super into that, guys, but it's like in these tiny little cells, you have like like nutrients being lost and then nutrients being reabsorbed depending on what is happening within the body. And what I mean like say nutrients is like in the glomerulus you'll have sugar that is lost, okay, in the glomerulus, but in the proximal tubule, if sugar levels are at a normal level in our body, we'll actually reabsorb those. So we shouldn't be urinating sugar. But when sugar levels get too high, well, we don't reabsorb it anymore and we let it out in the urine. Also, sodium will get lost and then also reabsorbed within the kidneys. But if we have, like, say, diabetes insipidus, where we're, urinating excessively and we're losing fluid, that plays a role in losing, a nice balance of electrolytes because we're constantly dumping water. I know, kind of getting deep there, but understand it helps us just create a balance. Now, into medical terminology. Now, we have our prefixes, suffixes, and our combining form. Now, guys, like I said, this is a semester class in and of itself. Up on this slide are some of the basic prefixes, okay, and suffixes to become familiar with. There is not enough time to like dive into each one of these, unfortunately, but understand when you see like hypovolemia, hypoglycemia, okay, hypotension. Hypo is referring to low or below normal, okay. Hyper is high or above normal. So if I have hypertension, tension is referring to pressure, hyper above normal, high blood pressure. Hyperglycemia, glyco is referring to glucose, hyper is above, therefore hyperglycemia, okay, is high blood sugar. Okay, when I have a or I at the end of my medical term, okay, that is going to be referring to a condition. Okay, so hypovolemia, hypovolemic, okay, condition of the blood, low blood volume. Okay, tachy, fast, brady, slow. So when I say tachycardia, ia is a condition, cardi pertaining to the heart. Okay, tachy means fast, so condition of a fast heart rate. Okay, brady, slow. Neo, okay, referring to breathing. Say bradypnea, okay, condition of slow breathing. Okay, again, there's a lot. What I always tell students, because they try to go through and I think they give you a few pages of medical terms. Whenever you hear something and you don't know what it means, ask the question, because you're going to have instructors that they're going to go through the class and they're going to be using medical terms just because they're comfortable with it, and you may not know what it means. Ask the question, add it to your tool belt, guys. I'm always learning. I'm an ER nurse now, and I am learning medical terminology still. I'll see something new or hear something new, I'm like, what does that mean? But I ask, so you're adding these to your toolbox. So with that, knowledge of anatomy and physiology helps with understanding patients' signs and symptoms and the treatments EMTs provide. Anatomical terms and planes provide point of reference for describing assessment findings. And then medical terms make up a specialized language shared by healthcare professionals. Okay, allows for clear, hey, the patient's tachycardic, just we have a term now for a fast heart rate that allows for clear, concise communication amongst healthcare professionals. All right, that concludes this period of instruction. Thank you for your time.